All right, well, good afternoon and welcome everyone to the fourth and final presentation in the Joint Legislative Council Symposia series on early access to autism treatment. My name is Andrea Brower and I'm a staff attorney with the Legislative Council. Today we are going to hear a discussion about policies that affect payment for autism-related services, and this will include a presentation from staff from the Department of Health Services and the Office of the Commissioner of Insurance. Before we get started, I've got a couple of technical items to go over. At the end of the presentation, there will be time for questions. If you registered for this event and are attending through the WebEx event platform, you can submit questions online at any time by entering them into the Q&A panel. If the Q&A panel isn't already open on your screen, you can open it by clicking on the QA button in the lower right-hand corner of your screen. And if you have any technical issues, you can contact LTSB technical support. For those of you who are watching via WebEx, please also note that this event is being recorded. So this is the final presentation in this Symposia series. And we just wanted to say thank you to everyone who has participated, and we're looking forward to a fruitful discussion today. So with that, I'm going to send it over to Representative Hesselbein to introduce our panelists for the day. Thank you, Representative.
Well, thank you so much, and thank you for inviting me today. I really appreciate being here with all of you. I'm really pleased to introduce today's presenters. First, we're going to hear from Scott Allen, who is a self-advocate on the autism spectrum. Scott has a master's in counseling from UW-Whitewater. He has been involved in autism advocacy since 2002 and has also served as a co-facilitator in research programs on autism through the Weizmann Center. Following Scott's comments, we will hear from Julie Walsh, a senior attorney with the Office of the Commission of Insurance, regarding the state autism coverage mandate for private insurance. Then we will hear from Pam Lano and Deb Wathermill, who work in the Department of Health Services Division of Medicaid Services. Pam is the section manager for behavioral health policy in the Bureau of Benefits Policy, and Deb is the director of the Bureau of Children's Services. They're going to provide an overview of Medicaid policies related to coverage of autism treatment, and will also discuss other state policies and programs that serve children with autism. Thanks again for having me here today. I'm really looking forward to the discussion we're going to be having. And welcome Scott, Julie, Pam, and Deb. I will now turn it over to Scott Allen.
Okay, unmuting. Thank you, and I'm honored to be here today to advocate for the rights, fair opportunity, dignity, and personal growth of people on the autism spectrum. Apologies in advance for going long. Legislation has never been a specialty of mine, so the perspectives I'm about to share must necessarily be about the broader sociocultural context of adults on the autism spectrum and how childhood autism services impact their lives. Children are future adults, and as I see it, a respected, meaningful adulthood is the ultimate goal of autism supports during childhood and adolescence. I strongly endorse maintaining and expanding a wide range of supports for children and adults on the autism spectrum. Under no circumstances, within reason, do I endorse reducing or eliminating the amount of support available to people on the autism spectrum. However, the kind and quality of that support, not only its quantity, is key, and something that I will address today. Before I go further, I must provide you with the context for where I'm coming from. As both a mental health professional and a person on the autism spectrum myself, I've been in a rare position to observe how the historical and cultural assumptions of neurotypical society have shaped the American approach to autism, and how this impacts the experience of living on the autism spectrum. This has taught me that the medical and behavioral model, which sees autism as a pathosis to be reduced or eliminated, contributes to an overwhelming sense that people on the autism spectrum are not legitimate, not valued, and to be pitied, appeased, or scorned rather than accepted or embraced. In particular, the notion that autism should be cured is profoundly dehumanizing, because it says to people like me that others think we should never have been born, and that it would be better if people like me were prevented from being born in the future. If that attitude were applied to any other marginalized identity, we would, I hope, be horrified. Therefore, my starting point for all autism advocacy is this: how can we on the spectrum live well, be confident, have dignity, and thrive in a society that often implies we're not really supposed to exist? I will not sugarcoat the very real and serious challenges, yet we must assert our right to be who we are. In most ways, I see autism as being a difference of identity. This is the neurodiversity model. Autism is neurologically and socially more complicated than many other minority identities, which is why I favor using multiple lenses as needed to better understand autism. Overall, I strongly favor the neurodiversity lens, but I acknowledge that it's not perfect and that the medical and behavioral lens does sometimes have relevance. In my autism work, I also use cultural, historical, and existential lenses to provide a much more complete, robust, well-rounded, and adaptable understanding of autism. These lenses are unfortunately not widely used or appreciated in professional autism supports. The fact is that adults on the autism spectrum are still quite poorly researched, and the long-term impacts of childhood autism treatments are, likewise, not well understood. Therefore, we have to lean more heavily on the self-report of adults on the spectrum than we otherwise might. Those self-reports are often grim, painting a picture of perpetual difficulty in an indifferent or antagonistic society. In particular, I am compelled to report on the passionate and often bitter controversy regarding ABA therapy. A disturbing fraction of adults on the autism spectrum who went through ABA therapy report it to be traumatic or abusive. I was diagnosed at age 15 and I never had any such treatments, so I consider myself an outside observer in that sense. Yet I am haunted not only by the sheer number and vehemence of ABA therapy survivors, but also by how their voices have comparatively little political influence in the face of the ABA therapy industry, which is a $2 billion industry in the US, and of its nonprofit supporters. With any group impacted by a policy, it's essential to listen to the affected people themselves. It is beyond disheartening that adults on the autism spectrum are still treated as a fifth wheel compared to the complex of parents, advocacy organizations, researchers, and treatment providers, most of whom are good and sincere people, but their voices usually drown out ours, and that is a distressing position to be in. This very symposium, as originally planned, included no adults on the autism spectrum. I'm glad that was addressed when it was challenged, but the fact that it had to be challenged is sadly representative of these issues. However well-meaning other stakeholders may be, they are not us on the spectrum, and though I welcome thoughtful non-autistic voices on these issues, they can never be a substitute for our own voices or our own lived experience. This is borne out by research. For example, a 2014 study called Autistic Expertise, a critical reflection on the production of knowledge in autism studies, states, quote, autistic people have often become distrustful of researchers and their aims and are frequently frozen out of the processes of knowledge production, end quote. And further, that, quote, the involvement of autistic scholars in research and improvements in participatory methods can thus be seen as a requirement if social research in the field of autism is to claim ethical and epistemological integrity. In other words, nothing about us without us. Some former practitioners of modern ABA therapy have gone on record as saying that what they did was a form of child abuse, yet there are also some adults on the spectrum who report being helped by ABA therapy. So I'm not dogmatic about this. I'm a fan of taking things on a case-by-case basis. In fact, there are many forms of ABA therapy, not all identical, and it has even been said that many therapies that are not ABA call themselves ABA in order to be covered by insurance. However, because of the extensively self-reported potential for disproportionately negative impacts on mental health outcomes for adults on the autism spectrum, I cannot in good faith endorse or condone ABA therapy without much more extensive investigation, debate, and addressal of the issues brought up by ABA therapy survivors in the adult autism community. There are also good alternatives to ABA therapy, and I maintain that they should be funded much more extensively than they are today. The Autistic Self-Advocacy Network, ASAN, the world's largest advocacy organization run exclusively by and for people on the autism spectrum, has this to say. Many therapies can be helpful for autistic people, like physical therapy, speech therapy, occupational therapy, and augmentative and assistive communication. We think these therapies should be easier for autistic people to get. But there are some therapies that focus on making autistic people seem normal or appear less autistic. The most common type of this therapy is applied behavioral analysis, ABA. ABA uses rewards and punishments to train autistic people to act non-autistic. ABA and other therapies with the same goals can hurt autistic people, and they don't teach us the skills we actually need to navigate the world with our disabilities, end quote. In 2017, ASAN published a report called First-Hand Perspectives on Behavioral Interventions for Autistic People and People with Other Developmental Disabilities. That report quotes one adult on the spectrum who received ABA therapy saying, the therapeutic goal was presented as learning social behavior. In retrospect, this was learning to mimic neurotypical social behavior. It resulted in corrosive damage to self-esteem and deep shame about who I really am. No effort was made to explain autism to me or to explain the role of sensory overload in issues like meltdowns, shutdowns, etc. End quote. The report goes on to say, Participants preferred treatments to focus on skills that would help them understand their own disabilities and coping with sensory overload, as opposed to therapies that made people look less autistic on the surface. Therapies that participants considered helpful included occupational therapy to help with sensory integration, play therapy, social skills groups for children, job coaching, mentoring, and mindfulness to help with anxiety. All the therapies suggested were aimed at encouraging self-determination and self-care rather than indistinguishability from their peers. On the other hand, participants thought that therapies designed to make them appear superficially non-autistic did more harm than good. For example, stimming or repetitive movements that many autistic people use to calm down or focus should not be suppressed if there is no physical harm to others. End quote. I agree, and my work with fellow adults on the spectrum strongly corroborates this. Even those adults on the spectrum who have not received any kind of treatment, and that is many of us, tend to be trained by society to reject or doubt themselves and to internalize stigmas about autism. In contrast, I know that it's possible to be on the spectrum and to have a healthy identity that accepts or embraces these neurological differences. A large number of adults on the autism spectrum report that not only ABA therapy, but the medical model overall trains them how to conform to questionable cultural assumptions, and that it does not teach them how to assess, prioritize, or pursue their own unique needs, goals, or self-expression. In my work, I've seen that this leaves a great many adults on the autism spectrum very prepared to go with the flow of society no matter what, and very unprepared to make mature, confident, enlightened decisions about their own best interests. I've seen this over and over in my work with adults on the spectrum, people who have been taught to suppress their individuality and who therefore are timid, passive, and uncertain about how to be fully engaged members of society. They know that their way of being is devalued, and in response, they mask their struggles. In fact, there is a terrible irony that whether through formal treatment or informal social pressure, people on the spectrum are told that they must hide their symptoms in order to appear normal and respectable, to not be rejected or discriminated against. Yet when those hidden struggles finally become overwhelming, and such an adult on the spectrum seeks help, they are too often told, well, you look very normal. So either you're not actually autistic, or you are, but you don't deserve the help. How gruesome to be trained to keep up appearances and then be told that your pain and your problems aren't significant because you have succeeded at looking normal like other people insisted you must do. In contrast, those adults on the spectrum who were taught to balance self and society tend to be much more emotionally successful in my experience. As a state and a nation, we can do far better than this. And the best time to head off these psychosocial problems is in childhood, when both autistic and neurotypical children can be taught that autism should be accepted and supported, rather than hidden, overridden, and kept in the obscurity of shame. If you think that teaching communication, self-care, and conformity is good enough, you're deeply mistaken. In my professional development over the past decade, I have grown increasingly frustrated by the narrow focus on skills with very little fluency in teaching cultural context, personal values, healthy identity, and the vital questions of human existence. Again and again, I encounter clients on the spectrum who have been taught or browbeaten to seem normal, yet have no healthy answers to questions like, do I have worth? Do I have a legitimate place in society? Will I always be alienated? Can I be loved? If we teach social skills for a society that is going to reject these souls anyway, how can we claim to be treating their condition? What about their human condition? In my view, supports for adults on the spectrum, starting in childhood, must include identity development, exploration of cultural values, and self-advocacy skills if we are to expect people like me to navigate a society that is not designed for us and which continues to be basically opposed to our natural perceptions, interests, and self-expressions. Adults on the spectrum have potential that is worth every penny that society invests in them, yet that potential is deeply undermined by the mental health pressures imposed by a society that mostly does not understand and often does not care. Whether informally due to the stigma, rejection, and punishment by family members and society at large, or formally as with ABA therapy and other therapies that emphasize training toward a neurotypical standard rather than supporting toward an autistic standard, I end up encountering adults on the spectrum who feel worthless, alienated, confused, and frustrated, even when they have strong communication skills, social skills, and are well educated, whether or not they had childhood treatment. In fact, at least 50% and perhaps 80% of adults on the spectrum have clinically significant anxiety, depression, or both, largely due to challenges needlessly imposed by society. The fact that outwardly successful adults on the spectrum are so often racked with struggle and inner turmoil tells me that existing treatments and training alone are not sufficient for psychosocial well-being, and that supports for the whole person are woefully absent and desperately needed. I see it as crucial that such supports begin in childhood, so that rather than counselors like me helping to manage autistic emotional trauma later in life, those emotional traumas can be avoided and healthy autism identities can be built up from a young age. One of the core messages of my autism advocacy is that culture plays an enormous role in interpreting and acting upon neurological differences, which in turn plays a huge role in determining opportunities and outcomes for us on the spectrum. Interpret autism as a medical condition, and everything about it will look like a symptom to be targeted. Interpret autism as a problem of human relations, and suddenly it looks very much like a matter of social inequality and cultural prejudices unfairly holding back the well-being of a group of people. Supports for both children and adults on the spectrum should reflect this. Most people on the autism spectrum face some serious neurological challenges. All people on the spectrum face challenges that are created or worsened by cultural factors, by the ignorance, apathy, exclusion, and hostility of others. The bottom line is this: we are devalued. We are told that we are not good enough by the standards of society, so the dominant treatment regime attempts to make us good enough. Yet change those cultural standards, and you may change how we are interpreted by others. Autism is addressed not only by changing the person, as in the medical and behavioral model, but also by changing how society reacts to the person, the social model. If typical autistic behaviors like self-soothing, unusual interests, and communication differences were truly accepted by society, rather than subjectively labeled as undesirable behaviors to be trained out of the person, that would go a very long way toward making autistic lives far more manageable and far less confusing, threatening, and exhausting. It would certainly not solve every issue, but it is my position that support services that don't consider the need for societal change are merely a bandage on the social wounds rather than genuine social healing. I endorse legislation for autism programs and supports that empower personal choice and personal meaning, not conformity to arbitrary neurological or cultural standards. And we as people on the autism spectrum should have an important and clear role in defining and refining childhood autism therapies. Nothing about us without us. In 2019, I co-founded the Integral Autism Conference. I defined and wrote its mission, vision, and value statements. And my goal in doing so was and is to get adults on the autism spectrum in the same room with parents, providers, researchers, and other stakeholders of the autism community, so that we can all learn from each other, and so that we as adults on the autism spectrum can converse and engage and not be easily dismissed. This year's Integral Conference is coming up on October 24th, and this time around is focused mainly on the impact of the COVID-19 pandemic. I extend my personal invitation to everyone involved in these proceedings to attend Integral this year and in future years, so that you can interact directly with adults on the spectrum and hear from them about the challenges they face and the strategies that they are seeking. Our website is integralautism.org. Thank you for this opportunity to address the broader horizons and farther trajectories of autism in American society, in Wisconsin in particular. I leave you with 8 words. Please listen to us. Please listen to us. Thank you.
Well, thank you, Scott, for that, for those comments. It's really helpful to hear about your experiences and your perspective. Scott will be back for the Q&A portion at the end, so feel free to put any questions that you have for him into the chat box. Next, we're going to hear from Julie Walsh from the Office of the Commissioner of Insurance regarding insurance coverage for autism services. Go ahead, Julie.
Hello, and I'm just going to get my slideshow up for you. Great. So I believe you have my screen. Is that correct, Andrea? The slides are in front of you?
Yes, that is correct. Is it possible to do the other version of the PowerPoint? What we're seeing is
Certainly.
your internal notes. That one is the correct one. Yep, thanks.
All right. And I just need to see my other one. So I'll just give you a second there. Now you see it. Great. So what I wanted to do is let you know, one, that I have heard all your presentations, and I really appreciate the comments that have come from so many different providers and consumers. And Scott, if my daughter, who also has autism, was listening to your presentation, she'd be cheering you on, so thank you. I heard gaps in coverages for current rules on the self-insured employers that happen right now with coverage, that only domestic insurers are covering the mandate. People can't afford the diagnostic tests, that travel's not covered for providers, so families are having to travel great distances for services. Evidence-based practices is not clearly defined and permits discretion from the insurers. Parent participation requirements should allow more flexibility, and minimum hours are than stated are actually being required in our administrative rule. So let me give you a very short time capsule. So remember, this rule was actually, and the law was actually passed in 2009. It arrived on the heel of the Mental Health Parity and Equity Act, MAPIA, that was generally effective for plans beginning after October 3rd, 2009. One of the definitions within the autism statute is that it is the mental health condition of autism that was to trip this parity. It preceded the PPACA, the Patient Protection and Affordable Care Act of 2010, and under the ACA, beginning in 2014, qualified health plans are prohibited from imposing pre-existing condition limitations and cover preventive screening, including screening for autism at ages of 18 and 24 months. And also, when this law was enacted, there was no certification process in the state for behavior analysts using the science of applied behavior analysis. So what the mandate requires is that every disability insurance policy and every self-insured health plan of the state or a county or city, town or village or school district shall provide coverage for an insured of treatment for the mental health condition of autism spectrum disorder if the treatment is prescribed by a physician and provided by those who provide intensive level services or non-intensive level services. Intensive level services mean evidence-based behavioral therapy that is designed to help an individual with autism spectrum disorder overcome the cognitive, social, and behavioral deficits associated with that diagnosis. Non-intensive level services means evidence-based therapy that occurs after the completion of treatment with intensive services, and that is designed to sustain and maximize gains that were made during treatment with intensive level, or for an individual who has not and will not receive intensive level services, evidence-based therapy that will improve that individual's condition. The coverage required may be subject to deductibles, coinsurance, and copayments that generally apply to other conditions covered under the policy. The coverage may not be subject to limitations or exclusions, including limitations on the number of treatment visits. So in a nutshell, this screen tells you that initially this had a dollar maximum for intensive services of at least $50,000. They must begin for intensive treatment between the ages of 2 and must begin before the age of 9. And the time limit is 4 cumulative years. Because these kids often have multiple health issues going on at once, there are times that intensive therapy is not doable, either for the individual or for the family. So we wanted to be sure that maximum number of hours are provided for the child. And the minimum treatment hours is an average of 20 hours. And as I get into the next slides, I'll explain why they chose a number that was less than actual numbers in the statute. So what the statute does not cover is a self-funded health benefit plan from an employer that's subject to federal jurisdiction, which is ERISA. So one of the presenters raised the point that their employer insurance did not cover autism mandate and then later on it did. And ERISA is managed by the Department of Labor, and there are a few legal terms that we play with, which is the preemption clause, a saver clause, and a deemer clause. And there are areas that the Department of Insurance does have jurisdiction with employer-sponsored self-funded plans, but that's DOLs. When an employer uses a fully insured product, The office does have jurisdiction, and we work in, as long as we don't prevent the application of the federal law, we are able to impose our state law. Group health plans issued in other states that have employees in Wisconsin. So we have jurisdiction once the number of employees in Wisconsin reach at least 25% or above, and then all the laws of Wisconsin are required to be complied with by that plan. So what this coverage looked like from the consumers when this first started is self-funded insurers made up approximately 38% of the marketplace. So those are the people that one of the fathers who spoke, I believe last week, is in that hole, in that gap. Unfortunately, a statute or a regulation is not going to fill that gap because of the Department of Labor's preemption. Public plans, so this is going to include Medicaid as well as Medicare or dual eligible individuals. Private insurance is about 28%. This was at the time in 2007, and uninsureds were running about 5%. Today, just a quick look. This is from the Kaiser Family Foundation. Public coverage is coming up at a similar rate. The employer-sponsored coverage demographic is about 57%, and the difficulty is that it's combined. I can't tell from the data how much of this is self-insured versus how much of this is fully insured group products. Non-group products is actually a smaller percentage than it was in 2007. Uninsured is currently only at 6%, so that's pretty good for Wisconsin maintaining that base. So the mandate required us to define 4 terms and then to promulgate rules. And I'm going to see if I can get to my other screen. So Commissioner Dilwig, who is in office at the time for the Office of the Commissioner of Insurance, acted immediately because we had only a 5-month lag before the effective date of this law to get some emergency rules in place. So the commissioner pulled together this autism working group who was made up of Senator Robson, Senator Carpenter, and Representative Hickson, as well as parents and autism organizations that represented the kids in the programs as well as families, insurers and insurance associations, autism providers, and DHS representatives, as well as obviously the office was there. So this was a very vibrant group, and this group actually met every other week beginning in late May and continued actually through the permanent rule time, where we were able to get an emergency rule effective by November 1st, which was the effective date of the law. An amazing group, and these were 3-hour sessions, and we slugged through just about every issue possible. It was amazing teamwork. The administrative rule started with the base as the waiver program, but we didn't stop there. That was just a starting point. We had presentations from Linda Tuckman from the Weissman Center. We had providers who were both on state, local, and national programming who were leaders in research and access to those programs. And we looked at current literature on autism spectrum disorders and information from other states that were also implementing this mandate about the same time or just ahead of Wisconsin. The research and literature in the realm of autism was rapidly evolving, and that led the working group to start focus on defining terms that were within the statute, like evidence-based and behavioral, rather than creating a list of approved therapies that could get out of date very quickly. The rule also addressed several administrative issues. It allowed insurers to indeed deny claims that they believed were fraudulent, to exclude travel time because of a finite pool of money. The insurers felt strongly, as did the providers and the parents, that the hours that were going to be funded really should be for treatment, and allocated that money in that manner. As you heard from some of the presentations, some providers have built travel time into their negotiated rate with insurers. It ensured treatments were evidence-based, and that is still current leading national clearinghouse on autism spectrum disorders, the same philosophy that is still touted today. And to give the rule a longer view for its application, the role of research, advancements, and what would qualify for efficacious treatment or efficacious strategy was discussed at length. and reliance on the Weissman Center, the national organizations, existing laws and regulations from other states was incredibly informative for this group. The rule has these definitions built in, and these were worked over several meetings with debates going back on whether or not things needed to have ands and ors, and if that literally made and did make a difference for the people receiving services. Evidence-based therapy, as I said, is critical. Everything that we are hearing is that we need to be sure that these programs that are provided to consumers do not do harm. I'm concerned for the patients that Scott has worked with, and one of the goals was to make sure that there would not be harm for these children or any person. So this is one of the first times people who didn't even have, like Scott, who got diagnosed at 15, would still get services by having this non-intensive option and being funded. The intensive level services required a parent or a legal guardian to be present and engaged. That was multifold. One was to be sure that there was someone speaking for the child if the child could not speak for themselves, that the treatment that was being provided was fair and equitable and was appropriate, that the parent being engaged, these were only so many hours that there was therapy. The rest of the time is with the family, and to be sure if there were strategies that were working with a child during this intensive time, that they could be strategies utilized by the caregiver or the parent if they're taught that process by being present during these therapy sessions. The location of service was still and is focused on where the child is. So there are exceptions if some of the therapies or behaviors need to be worked on in different settings, but primarily in the home, especially with these younger children. They do need a verified diagnosis. This is insurance that we're talking about, and it is critical, although I know there's a question about trying to reach those who may not have the diagnosis yet, but who are demonstrating need. For tripping this level of services, the insurers and the researchers and the providers really wanted this to be a verified diagnosis, that they got a cumulative 48 months. There are times kids get sick, and we didn't want them to lose treatment time just because of that. And that the verification of service by the providers, that everyone was credentialed, that they were certified to provide these services to these kids, and that one of the things that we wanted to be sure that we did is grandfather in existing providers. So who are qualified to provide services to the residents of Wisconsin diagnosed with autism? There's an entire section of the administrative rule, and I'm not going to read it to you, but that goes through in depth the hours of training they need, and not just with children, but specifically children with autism or adults with autism, because those are different needs. As one of the speakers said, when you have seen one child or one person with autism, you have seen one person with autism. Why is there a requirement for parents and caregivers to be present? Safety, learning, consistency. Those were all discussed at this working group. And by the time OCI was drafting the emergency rule went in November, the permanent rule was enacted and effective October 1st of 2010. Wisconsin Act 2009-282 was actually enacted, which provided some licensure and regulation over behavior analysts, provided insurance coverage for those services for the treatment of autism. So this is current requirements under the National Clearinghouse for Autism Spectrum Disorders, and it is the criterion for what is evidence-based practice. And if you see this and you compare it with our existing current rule, you will follow that we are still in compliance with that. So the rule that this working group came up with is still lively and living today because we did not put in too many restrictions. Just to be aware, there are therapies that are indeed restricted from the administrative rule, and those are therapies that at the time the rule was going through were proven to be harmful, like chelation therapy, which is ridding a person's body of toxins. It's appropriately used if there's been like lead poisoning, but it has been found harmful if it's being given to people who do not have that. A lot of parents we were hearing during the working group were feeling fairly desperate to either find a cure or to find some way to navigate having a child with autism. and they were willing to listen to just about anyone who was willing to try to work with their child. So these guardrails were put up both for the insurers, but also for the families and those who have autism, so that they may be protected and not harmed. Finally, I just want to leave you, and this presentation will be available with some resources. So OCI set up both frequently asked questions regarding the autism mandate. The rule itself is available. We also provided additional guidance to clarify that one of the rights that we added into this mandate through the rule is the right to be able to grieve and appeal both the level and the diagnosis of treatment that a person receives. And finally, we do have a really nice publication on mandated benefits generally. So I'll hand this back to Andrea. Thank you very much for your time today.
Thanks, Julie, for the overview of the insurance mandate. Now we're going to send it over to Deb Rathermel and Pam Leno from the Department of Health Services to talk about Medicaid coverage and other programs available through DHS. Pam, it looks like you're on mute.
Having a problem with my screen.
We can hear you now, Pam.
Awesome, thank you. Sorry, I have multiple screens open here, so thank you for your patience with that. All right, so we're good. You can hear me and we have my screen up? Terrific. Yep. That's great. So I am Pam Leno, and I work as the Behavioral Health Policy Section Manager for the Division of Medicaid Services. And where I'd like to start today is just to provide a brief history of autism treatment in Wisconsin, and specifically what's been funded by the Medicaid program, just to provide some context. So Wisconsin Medicaid has been covering autism treatment through one mechanism or another for more than 25 years. The state started coverage in 1994, and in that year, the total expenditures were less than $2,500 for the year. But within 8 years, those expenditures had grown to almost $32 million per year. Eventually, CMS indicated that in-home autism treatment could no longer be covered as a card service. So starting in 2004, the program transitioned to a home and community-based waiver program. So autism treatment became one service among a whole array of services that were funded by the Children's Long-Term Support Waiver. And it was funded through that waiver for over a decade. Then in July of 2014, CMS released an informational bulletin indicating that autism treatment had to be funded under EPSDT for individuals under age 21. Now, EPSDT is a special provision in the Social Security Act, and it requires state Medicaid programs to cover preventive, screening, diagnosis, and treatment services to children when the services are determined to be medically necessary for the child's needs. So that meant the need to create a new Medicaid benefit to provide treatment for children affected by autism. Now, each iteration of Medicaid autism treatment coverage has come with its own unique configuration of covered services, program administration, and the approach for obtaining services. The original program that provided up to 40 hours of treatment each week through age 16 was probably not expected to grow as much or as quickly as it did. And then under the waiver from 2004 to 2016, the program came with some new limits on the number of children who could be served, the age of children who could be served, and the number of years they could receive treatment, because the waiver was operating within a some certain budget. Now, when the current benefit launched in 2016, some of the waiver limitations went away, but the concept of medical necessity became newly important because medical necessity is the basis for providing coverage under EPSDT. So the point is, in the same way that commercial insurance coverage may be dictated by legislative language, there are some aspects of Medicaid covered services that are dictated by federal Medicaid rules. Now, to give you a perspective on what this coverage entails from Wisconsin Medicaid, this is just a brief overview of our current behavioral treatment benefit. So the primary goal of behavioral treatment is to prepare members and their families for successful participation in normative settings and activities at home, in school, and in the community. So real life, just helping them be well prepared for real life. So the Medicaid coverage of behavioral treatment, as I mentioned, started in 2016. The benefit currently allows for 2 evidence-based treatments, ABA, which is applied behavior analysis, and also the Early Start Denver model. So that is a more play-based, developmentally informed approach to treatment. Both of those have a strong evidence base, which is why they're both covered. Now, in Wisconsin, we expanded beyond the CMS requirements, so there are no age limits for the behavioral treatment benefit, and the benefit isn't restricted to members with autism. So that's part of why we decided to call it behavioral treatment instead of autism treatment. Now, broadly speaking, the benefit covers 3 forms of treatment, and the first of those is comprehensive treatment. So comprehensive treatment is that early intervention approach that many of you think of. It's designed to address multiple aspects of development and behavior in young children. It typically involves a high number of hours per week. So often it can be anywhere from 20 to 40 hours a week. And it typically occurs over a long duration of time. So certainly more than 1 year, and frequently individuals participating in comprehensive treatment are in for several years. Now, members aren't limited to a certain number of years of comprehensive treatment under the Medicaid benefit. So the service can be authorized as long as the provider's documentation substantiates that comprehensive treatment is medically necessary for the member. Based on research evidence regarding treatment efficacy, we typically expect children to complete comprehensive treatment by around age 8 or 9 or 10. Now, the second form of treatment that's covered is focused treatment. So focused treatment is designed really to address a more limited scope of either specific behaviors that are challenging or potentially skill or developmental deficits that are keeping the member from fully functioning. Focused treatment typically includes a lower number of hours per week. So I would say 5 to 15 hours is pretty common. And it's a shorter duration. So we typically expect the goals that are being targeted to be addressed within a year. Now, members can receive focused treatment as a starting point or as a step down from comprehensive treatment. The focused treatment benefit is flexible, and it allows members to complete a course of treatment and then be discharged from treatment and then restart treatment again at a future date if behavioral needs arise. So that means that members don't have to stay continuously engaged in focused treatment in order to have access to it. And then the final form of treatment within the benefit is called family treatment guidance. And so family treatment guidance is about training parents and caregivers to use some of the treatment techniques that they've seen for either teaching the child new skills or for managing challenging behaviors. And it's designed to prepare families to take over generalization and maintenance of skills that the child acquires during treatment. Now, Wisconsin Medicaid has placed a special emphasis on the importance of family training, and that's based in part on some long-standing research evidence that best outcomes are often associated with family engagement in treatment. So we expect providers to engage and train families so that the families can support skills and manage behavior when treatment isn't in session. And the purpose really is to help the whole family move toward more normative participation in family and community activities. So in terms of the number of individuals impacted by this new benefit, this chart reflects the number of members who received either comprehensive or focused treatment in each year since the benefit has been in effect. Now, these numbers reflect the members who received at least some direct treatment service that was reimbursed by the Medicaid program. We know that there are a lot of members who have Medicaid as a backup to their commercial insurance, and sometimes Medicaid is just there as a backup and it doesn't get utilized at all. So those numbers are not reflected here. This is just for members who actually received a treatment that was reimbursed by Medicaid during one of those years. And you can see that there has been a climbing number of members receiving treatment. Now, this chart reflects the total number of hours of direct treatment that were reimbursed by Wisconsin Medicaid for each of the years that the benefit has been in effect. So members also benefited from family treatment guidance and team meetings, but those hours are not reflected in this chart. So this is just the hours of direct service. So that would be like the one-on-one treatment that was provided. And you can see that in 2018, that was the first year that Wisconsin Medicaid reimbursed more than 1 million hours of direct treatment in a year. I also note that providers have a full year to submit their claims for services, so it's possible that total reimbursement for 2019 could still grow. But as you can see, there has been an increasing number of reimbursed hours of treatment each year since the benefit launched. Now, all of the treatment that's provided and reimbursed by Wisconsin Medicaid is supervised by licensed professionals who are directing and guiding paraprofessionals to render the service. So the benefit providers are very similar to the providers that are described in the commercial insurance mandate. So licensed supervisors for this benefit are typically licensed board certified behavior analysts. And then some of them are also licensed mental health clinicians. They're usually supervising the focused treatment. Treatment therapists are kind of a middle level manager who provide direct oversight for treatment technicians. And those treatment therapists have at least a bachelor's degree and what would essentially be the equivalent of a year of full-time experience before they start supervising other staff. And then treatment technicians are individuals who are at least 18 years old, have a high school diploma or its equivalent, and 40 hours of training that's typically provided by the autism treatment agency that they're working for. So most of the services are rendered by technicians with direct supervision by treatment therapists, and then licensed supervisors have oversight over the entire treatment program that's being offered. So this chart reflects the number of treatment supervisors, and that's predominantly BCBAs, the board certified behavior analysts, who rendered a service in each of the years that the benefit has been in effect. So the number of licensed supervisors has grown dramatically since treatment services were funded under the CLTS waiver. So right before in 2015, right before it became a benefit, and then each of the years that the benefit has been in effect. Some of that growth comes from national agencies that have come to Wisconsin to render services. But we've just anecdotally noted that a lot of that growth comes from young professionals here in Wisconsin who have risen through the ranks and who have decided to pursue the necessary degrees and certification to become treatment supervisors. And then this chart reflects the number of treatment therapists and treatment technicians that rendered service in each of the years the benefit was in effect. So you can see that there's also a more modest but still a growth trend in those numbers as well. So the bottom line in terms of changes in provider capacity is that provider capacity has grown substantially since the benefits launch in January of 2016. The number of treatment supervisors has more than tripled since the funding transitioned from the CLTS waiver. And we're really encouraged that we have had new agencies pop up in areas of the state that have been historically underserved. So we now know that there are Medicaid enrolled autism treatment agencies in Stevens Point, in Wausau, in Rice Lake, in Eagle River, and in Superior. We're encouraged by that. We know that those are areas where we have heard for many years that there was a need for more providers, and now we're seeing the beginnings of providers in those areas. Now, as I noted earlier, Medicaid coverage is subject to regulations in federal and state laws that may not apply to other payers. So Wisconsin Medicaid can only reimburse for services that are outlined in our state plan, and our state law allows Wisconsin Medicaid to reimburse only for medically necessary and appropriate healthcare services. I've mentioned medical necessity a few times already, so clearly it's an important concept for reimbursement by Medicaid. Medicaid determines whether a service is medically necessary for a member by using the prior authorization process. This means that providers are required to submit documentation, and their documentation needs to substantiate that the requested service is appropriate, expected to be effective, and not excessive in comparison to alternative care that could produce similar outcomes. In terms of the documentation required for the prior authorization process, when the benefit first launched, Wisconsin Medicaid requested a lot of documentation to confirm the medical necessity of each request. And it was a lot, and we know that you've heard about that in other sessions. However, over time, as our PA reviewers gained a better understanding of provider practices, our policy team significantly reduced the required documentation and has also worked to increase flexibility and access through the Medicaid benefit. Just a few of the important examples for you to know about include, first of all, we simplified the PA process for requesting services for children under age 6. So in 2017, the Medicaid program significantly reduced the required documentation for that particular population because we knew it was really important to expedite access to early intervention services. So we lightened the load for providers so it would be easier for them to get started with treatment for kids under age 6. We also started authorizing many services for up to 12 months at a time, as opposed to requiring PA every 6 months. And part of the goal in that was to reduce the number of times providers had to go through that PA process. Now, interestingly, even though those changes were published policy changes, our PA reviewers continue to find that a lot of the providers don't take advantage of those simplified processes. So even though the Medicaid program has tried to reduce the administrative work, we still have providers that send more information than is required, and a lot of them don't take advantage of the 12-month authorizations, and we're not sure why that's true. The last point that I want to make that's really important, especially in light of all of the conversations about early diagnosis and the challenges associated with that, is that Medicaid authorizes coverage even if a member hasn't gotten a diagnosis of autism yet. So if the provider's assessment demonstrates a need for treatment, our PA reviewers will go ahead and approve the requested treatment. So we still want members to pursue that diagnosis, but under EPSDT, we authorize treatment so that members can get started as soon as possible. We don't let the lack of a diagnosis be a barrier to early intervention for those young ones. To ensure a well-functioning program, Wisconsin Medicaid has worked really hard and really closely with a network of providers and other stakeholders, and we've made a lot of policy enhancements in response to their feedback. So just a few of the examples of policy changes that were made are provided on the screen. In 2017, we simplified PA processes, as I mentioned before. We also added technicians for focused treatment, just to increase access so that providers would be able to serve more members. In 2018, we worked closely with the Department of Public Instruction so that we could put out guidance explaining how all of the special education services offered through school districts could be coordinated with behavioral treatment and work together. So behavioral treatment is available in schools, and that whole memo explains how that can be done well. In 2018, we had heard from providers a concern about the reimbursement rates and how that was impairing their ability to adequately staff teams. So in 2018, we increased the direct treatment rates 33%. So it went from $28.64 an hour to $38.10 per hour for all of the direct treatment services, which was Medicaid's attempt to improve rates and make it easier for providers to attract more staff. And then in 2019, we removed the required medical evaluation and simplified PA forms, again, with the goal of removing barriers, simplifying the process for families, and simplifying the process for providers as well. Now, we feel pretty good about the benefit that we've developed and the changes that we've made since the benefit launched. It's been a very conversational back and forth process with our stakeholders so that we could learn what their pain points were and what improvements we could make. And we've made many of those along the way. And I think the result is a benefit that has created important access to behavioral treatment, which has been helpful for a lot of people. But that said, behavioral treatment is not intended to be a long-term support. We know that treatment isn't the best fit for every child and family. And even in situations where treatment is the best fit for a season, there are some members that are still going to have ongoing significant needs. And in those situations, our perspective is that behavioral treatment should function by preparing the member to benefit from whatever the next system of care is going to be. And often that's one of our long-term care programs. So at this time, I'd like to invite Deb Brathermel to speak about what those other support programs are for children with special needs.
Thank you so much, Pam. And if I got this right, you should see the screen in front of you. I got it right. I feel like I've succeeded at the most important task I had today. So good afternoon, everyone. I know we're at the hour for this session. And so in the interest of time, what I'd like to do is go through my slides by touching on some of the key programs that you've heard about over the series of sessions in the month of September, and get to kind of the last couple of slides, which is where we have identified some of the opportunities that we might be able to explore going forward for the future. So I think much of what you've heard today is that there are a variety of ways in which children with autism might get access to treatment and services. And what you're going to hear about here last is some of the other programs and systems of care that Wisconsin has to meet the needs of children with special needs, including children with autism. So as Pam indicated, this is the Bureau of Children's Services within the Division of Medicaid Services. And our responsibility is dedicated to honoring and empowering inclusive community lives for children with disabilities and their families in partnership with local communities by providing leadership and financial support through long-term care programs in Wisconsin. So for many families with children with disabilities, the needs do not stop at treatment. The Bureau of Children's Services is responsible for administering a number of programs targeted to supplementing the family health care coverage benefit and by providing community supports and services to support their child's special needs. So I'm gonna, again, highlight some of the most common programs for which we administer in our Bureau that do support those children and families. So ideally, when a family sees a need for special supports, they find the Birth to 3 program. The Birth to 3 program covers the first 1,000 days of a child's life and are among the most important in setting the stage for the future trajectory of all children with special needs. Children eligibility for Birth to 3 is based on a level of delay. Each state sets their own threshold for the level of access to enrollment. Wisconsin's criteria requires a delay in at least 2 areas of development, but does not require a diagnosis of autism to access the Birth to 3 benefit. The next program that is commonly accessed for children with special needs, including children with autism, I'm going to talk about 2 interrelated programs, Katie Beckett and the CLTS program. again, I'm gonna fly through them a little bit so that we can kind of get to the output, which is where are the future opportunities, and only spend enough time here giving you this context to give you a clear sense, I hope, of what is currently available to children and families in Wisconsin. So Katie Beckett is a form of Medicaid or an access to Medicaid for children and families whose parents would otherwise not be eligible for Medicaid due to their parents' income. Katie Beckett serves 8,000 children in Wisconsin who have long-term care disabilities. And then the children's waiver is the one that I think you've heard probably the most about over the last couple of weeks. The word waiver really just means a waiver from otherwise the Medicaid requirements for access to Medicaid funding. And that's exactly what we're able to do with the children's waiver, is serve over 11,000 children in Wisconsin with supports and services beyond the medical healthcare benefit and outside of the realm of acute and primary services. So the children's waiver provides community access services that support access, inclusion, and independence for children with special needs. A little bit of data on the Katie Beckett and the children's waiver both use a functional screen for eligibility determination. And you'll see that we serve for children whose first year of functional screen, that we have approximately 38%, pretty consistently showing of all the new kids coming to our programs, that about 38% of them do have a diagnosis of autism, and is staying pretty stable. And this data here shows us for the first time a child was screened for the program, at what age, and we are seeing what we like to see here is, right, that kids get to us earlier in their disability identification, and we are seeing that. Obviously, as we've heard, these earlier years, the 1 and 2-year-olds, we don't see a diagnosis of autism very likely in those first couple of years, based on some of the limits you've heard about over the last several weeks with access to diagnostic treatments and waiting lists for those accesses. But as Pam articulated, which is true in our programs, a diagnosis, while very important for other purposes in determining treatment modalities, is not necessary in order to access many of the programs that we're talking about here. Okay, so wow, I flew through that even faster than I thought I could fly through it. So the things that have stuck out to us over the course of these sessions, these last several Tuesdays, is a lot about access and a lot about what we think of as like a holistic service provision. So some of the opportunities for where Wisconsin could consider additional improvements in the realm of access is a system called No Wrong Door. One universal challenge in coordinating access to figuring out where to go. Families of children with special needs, including families of children with autism, are often not overwhelmed by the fact that their child has special needs as quickly as they're overwhelmed by not knowing where to go and how to get there. And few things are as powerfully challenging for a family than to feel like you don't know what to do to help your child. And that's true, right, for any parent, for any of our children. Whatever the challenges are, we want to be able to find and secure resources to help them be the best that they can be. So a No Wrong Door system is really just a fancy framework for thinking about all those places that a family or a parent might go when they first learn that their child has special needs, and really says they might come to any one of these systems first. a no wrong door approach looks at creating a seamless behind the scenes system where all children and families get access to what they need when they find themselves at that door. That includes features that you've heard about, such as the navigator is one concept that we often refer to. A navigator is really just the bureaucracy whisperer, right? They help explain whatever's happening. Whoever you find, that ambassador, that navigator, really is a person and a resource that can help you to figure out where to go next, right? Navigate or be your person through that process. The Department of Health Services has put forth a budget proposal in the last 2 budget cycles to fund a framework called the No Wrong Door. And again, this has many of the tenets that we're looking at to help children and families in these circumstances. And then finally, another area that we've talked about over the course of these series is about addressing the holistic needs of children with special needs, specifically in this case of children with autism. And as we shifting gears now a little bit here away from access, which the last opportunity was about, I also wanted to share with you a newly launched social and emotional innovation grants in our Birth to 3 program. As we've increased our awareness at the national level to support the social and emotional development of all children, has led to a heightened attention within the special services segment to increase our capacity to attend to these needs in our service delivery system. Over the past several years, we have moved away from a medical model of early intervention nationally and increased our focus on child development, supporting and growing parental capacity, and measuring our programmatic impacts on making gains in the social and the emotional development of children in our Birth to 3 program. This effort has led us to issuing social and emotional innovation grants to local Birth to 3 programs, because we do believe this is an area where we see potential to grow beyond what we currently know and what we currently do. So we launched these innovation grants on July 1st. They are 18-month projects, and they are, we have 15 different grantees throughout the state of different local county Birth to 3 programs. And they're exploring a wide range of improvements in our current program practices that we're seeing as the future of how we administer programs that are grounded in comprehensive social and emotional focus for children. And again, you'll see some of these examples are aimed at increasing coordination across different partnerships, lots of training. A lot of what we saw in our social emotional integration grants from counties was the need for our teams to have the training. And then some programs are trying a combination of all of these things, all of them based on a shared understanding that early intervention can change the trajectory of a child's future. It's a powerful opportunity that we see as a critical resource going forward. So again, huge flyby of the children's programs, and really wanted to spend my moments with you to talk about opportunities. And we see those opportunities in both a comprehensive access system, such as No Wrong Door, and increasing our attention and focus on our social and emotional development within our programs. How that wraps it up for me. I will turn it back over to our moderators.
All right, well, thank you to all of you. Those were really great presentations, and it's a lot of really good information. I know we're already a little bit over the time, but I think because I have you all here, I'd still like to ask a few questions. So I guess, and for those of you watching, you can still add some questions into the Q&A, although we don't have a lot of time. But I guess my first question is for Julie, Pam, and Deb, whichever of you wants to hop in. I guess if we take a big picture view at everything we've talked about, what do you think practically is really the biggest challenge to kids getting early access to interventions? You know, is it the fact that families have a hard time navigating the system? It seems like there are quite a few supports available and services available. And one of the things I'm wondering is whether you think there might be a role for the state to be a little more proactive in reaching out to families, you know, or maybe the family navigator is a better type of approach. So if you have any thoughts on that.
I think this falls, I have not heard issues with access for people through the insurance. So I'm going to hand off to Deb. But that is something that the Birth to Three Council, Interagency Council, is trying to address to get more notoriety out and word out that there are resources available.
Mm-hmm.
Yeah, yes, thanks, Julie. I think the concept here is what we refer to as child find, which is that as a state, we have a comprehensive responsibility to have a system of care for which children and families can find, right, what they need to do. And so the framework, such as the No Wrong Door, really does seek to establish more clarity, consistency, transparency, and uniformity for families of children with special needs to find their way through the mazes of all of the resources that might be available to them.
Do you think that the No Wrong Door model, it would be a complement to sort of the work that the family navigators that we heard from last week are doing in terms of, for those of you who weren't here last week, you know, it's sort of a model where an individual is assigned to help a family navigate, you know, all the different services that are available. Do you see those as complementing each other?
I think it's navigator is a concept that is often seen as a critical resource in the concepts that we're talking about here. So when we have a family who's faced with a complicated piece of information that their child has special needs and may need additional supports and services, those aren't words we're born understanding, right? Supports and services or systems. And so often improvements in our standardization of information, and then things like navigators, ambassadors, people that can give you that lay of the land from a family first kind of language, are pretty commonly accepted resources. Yeah.
Well, and I would say certainly it sounds like the programs that you're working on right now are pretty responsive to some of the concerns that we heard about last week. Mm-hmm. I have, Scott, if you're still on the line, I have a question for you about your comments, which is that you had talked quite a bit about the importance of self-determination for individuals with autism. And I wonder if you have some comments about, this Symposia series has been about early intervention. So I wonder if you have some comments about sort of how to harmonize the idea of self-directed, but also at such a young age. And, you know, I guess I wonder if part of that is through what you had talked about relating to teaching identity development, self-advocacy skills. So maybe you can comment on that.
Yes, certainly. It does involve those things like identity development, exploring cultural values, things like that, that are, you know, first learned in the deepest sense in childhood, within the family environment, within interaction with other people close to the child. It also starts with things like respecting their bodily autonomy and other subtle sorts of things. It doesn't necessarily include only that which is explicitly taught. It also includes unspoken messages of how they are interacted with, what kinds of expectations are placed on them, etc. All of these things are being absorbed subconsciously by the generalized child on the autism spectrum, and to varying degrees. Obviously, it's very difficult to generalize about people on the spectrum, so may not apply equally well or exactly the same in all cases. But being able to begin at a very young age, respecting their particular needs, their like stemming self-soothing behaviors, their interests. I was only 2 3/4 years old when I developed a quote-unquote fixation in dinosaurs, which is still one of the great joys of my life. And had that not been respected, had that been tried to be extinguished as an unusual or ineffective behavior, I would have been traumatized by that. So these kinds of things, they do present very legitimate challenges, especially in the context of interfacing with the rest of society. But that does not mean that they have to be extinguished necessarily. That means there need to be some degree of compromise, channeling, refinement of what the child is experiencing or how they're doing things. But ultimately, it should be centered on respect for the child's needs, self-expression, etc., so that from an early age, they are receiving the message that they are worthwhile individuals who can be confident about themselves in their world and feel that they are worth asserting their, as I said at the beginning, rights, fair opportunity, dignity, and personal growth.
Well, those are some really good comments. Well, I guess we are coming up at the end of our time here, but thank you all for your comments and for the time that you put in to prepare these presentations. This is actually our final presentation in the Autism Symposia series. So we wanted to just thank you all for tuning in. And next week, we're going to start a new Symposia series on workforce housing. It's going to meet on Wednesdays at 2 p.m. throughout the month of October. And next Wednesday's meeting is going to provide a background overview of workforce housing in Wisconsin. So we hope to see you there.